Hello, my name is Pedram and I'm an orthopaedic registrar at Monash Health in Victoria, Australia, and today we're going to be discussing shoulder arthroplasty in the Australian context. Over the past 2 decades, shoulder arthroplasty has undergone one of the most rapid shifts in all of orthopedics, and everything I'm presenting on today comes from the AOA National Joint Registry report of 2025, which has over 25 years of data with over 100,000 shoulder replacement, with the vast majority of those, about 90,000, being primary total shoulder replacements. Now, keep in mind that registry data is observational, so throughout this talk we're going to be looking at association, not causation. I'm deliberately restricting this talk to the 3 designs that we're going to see most commonly in our practice and what we're going to be choosing between, which is the total stemmed reverse, the total stemmed anatomic, and the total stemless anatomic. I'm excluding partials, resurfacings, and stemless reverses. They have a very small footprint within the registry. And the aim is to understand trends and why they're happening, what fails, why it fails, and how the registry data should change our practice. First of all, we're going to be talking about the scale and the direction of travel, not just our individual figures. So in population terms, the volume has more than quadrupled since 2008, and the growth is happening across all of our states and territories, and it's not a single unit or a single surgeon phenomenon that we're seeing. In 2024 alone, our volume rose 6.9% on the previous year. Shoulder replacements have moved from being a subspecialty interest to core orthopedic workload, and something that we'll be seeing our patients for, consenting them for whether or not we end up doing the shoulder replacement ourselves. There's been 2 main shifts that have sat underneath the growth. First of all, we now almost always replace both sides of the joint, with total shoulder replacements increasing to 90% of the workload from an initial 57% when the registry first started. And in line with that, partial shoulder replacements have been declining over the course of time. Secondly is our revision burden. Our revision burden is falling as a proportion even as our volume rises. So we were up around about 10.9%, which was our peak in 2012, and maybe that pertains to the learning curve of doing a shoulder replacement. And now, even though we're doing more, our rate of revisions has reduced to 7.5%. So in total, we're doing more cases, more totals, but we're having proportionally fewer failures. Now, this is what's really important for understanding modern Australian practice, and what we're looking at is the difference between the cumulative registry population and what we actually did last year. So comparing the 2 columns, the left shows us a whole 25-year registry, and the right is what our surgeons chose to do last year. So cumulatively, we have reverse sitting at 74.4% of primary totals, but in 2024, reverse was roughly 8,900 out of 10,000, so about 88%. What this shows is that cumulative rates always will lag real practice. So the left sided column actually ends up flattering anatomic replacements, but in reality, our stemmed anatomics are diminishing. Stemless is starting to take over, and the reverse is increasing its popularity even more. Now, the bottom row matters just as much. The operation is starting to be centralized, so lower volume hospitals barely feature anymore, and half of all of the cases that are done by the busiest quartile of surgeons. And most primary operations are being done by surgeons well past their learning curve. And also, preoperative CT is now becoming routine practice, whereas it wasn't before. Now, the outcomes that we're about to look at are largely the outcomes of the experienced, higher volume, well-imaged practice/surgeons. That's what we need to bear in mind before we start generalizing them to, the occasional shoulder surgeon. So, we need to be precise about what the registry is comparing, because it classifies by prosthesis and not by your intention. Now, the reverse converts the deltoid into a bit of an elevator, so the function of the construct no longer depends on a questionable rotator cuff tendon. Stemmed anatomics restore the native kinematics, but they rely on an intact, balanced rotator cuff, and it's basically only really being used for osteoarthritis. Stemless has the same anatomic bet and still relies on your rotator cuff, whilst preserving your metaphyseal and your diaphyseal bone for your next operation. One caveat that's worth noting is that the registry excludes modular metal-backed glenoids from its modern prosthesis analysis. So the stemmed anatomic that we're talking about effectively means a all polyethylene glenoid. Now on the right side in the blue box, what we're seeing is the direction of the indication mix rather than, absolute percentages. That's what we need to be really looking out for. For example, the cuff arthropathy is now starting to gain on osteoarthritis. So since 2016, osteoarthritis is down, almost 10%, but cuff arthropathy is up the same amount or a little bit more in that same period of time. And that is the indication creep that we're seeing towards reverse turtle shoulders. Now, the design is not used in the same patients. An essential message here is that any head-to-head comparison may have some confounders before it even begins. Reverse turtle shoulders is skewed towards the older patient, with almost half of the cases being in the over 75. Stemless is the youngest cohort by a country mile, with about 50% of them being placed in patients below the age of 65. And it's also the only class that has an even sex split, which tells you that we're selecting younger, often male, high demand patients for bone preserving reconstruction. Whereas, for example, in the stemmed reverse, the majority of the patients receiving those are female. Now, the stemmed anatomic sits somewhere in between the two. Now, why do we talk about this? Because when we see anatomic implants doing worse in the long run or having higher rates of revision in the long run, the obvious objection is that they were for different patients with different demands. And that's why the hazard ratios can be adjusted for age and sex, and why the residual confounding by indication and surgeon remains the limitation of all of the numbers that we're going to talk about. Now, when we're talking about cumulative percent revision by the class, all diagnoses are included. What we really need to be thinking of is not just the end result or the end point, but also the shape of the curve. So at 10 years, reverse sits at 5.5%, stemless anatomic sits at about 5.2%, stemmed anatomic with a polyethylene glenoid sits at about 7.9%. At 14 years, reverse slightly increases to 6.4% versus the stemmed anatomic, which is sitting at 9.5%. The reverse and the stemless are effectively indistinguishable after the first 3 months. The stemmed anatomic, that's partly because it doesn't dislocate early, but the graph starts to diverge and it keeps climbing whilst the reverse flattens out. And that divergence is what we want to take away. Anatomic failure is progressive and biological, and partly due to a rotator cuff that continues to degenerate. But the reverse failure is front-loaded and technical, clustered around stability and infection. And if the construct kind of survives that first little period, the first few years, then it's quite likely to stay put and the rates of revision stay low. The gap between the classes at 10 years is not a fixed offset, it's a widening one, and it'll look worse at 20 years than it does here. But one thing to keep in mind is that we don't have too many cases at sitting at that 14-year mark, and so we need to take those numbers at around about the 14-year mark with a grain of salt until we get more information. Now, the reverse is not one operation with one curve. It's actually got different curves depending on what the indication was for doing the reverse. Even though long term we're starting to see very similar numbers. Osteoarthritis and cuff arthropathy behave almost identically, which in itself is a point. Reverse doesn't utilize the rotator cuff regardless of what the indication was, and so because of that lack of reliance, those two indications behave very similarly. Fracture is the one that we want to be looking at. There's a clear early hazard, and that's likely due to tuberosity healing, humeral height, and instability. But after the first few months, it starts to track like any other reverse, and in the long term, it's no worse. And that clinical translation is about our conversation with the patient. So we warn the patient that fractures can do worse in the first year, but if they survive the first year, they are not inferior and they will do just as well as any other reverse that's been put in. The two indications to be more cautious of, especially at a glance, in looking at their curves, is inflammatory arthritis and instability as a primary diagnosis. Both of these carry an elevated hazard ratio across the entire period that we monitor them. Now, why has the reverse become so dominant? There's, three reasons that can be seen in the data. First of all, reverse deletes the dominant failure mode of the anatomic replacement. So cuff insufficiency is a leading cause of anatomic revision, sitting around about 28% for stemmed anatomics and about 25% for stemless anatomics. Cuff arthroplasty essentially never causes a reverse revision because we're doing a reverse in the setting of having a poor cuff. So you can't really fail a tendon that the construct doesn't rely on. Secondly, it's one system, but it's indication agnostic. It covers arthritis, cuff arthroplasty, fracture, revision, and it performs acceptably in all of them. In a centralized high throughput system, that predictability is worth a lot. And finally, the durability question has been answered well enough. It's no longer a salvage implant like what we used to do when reverses first came into favor. We're now sitting at 6.4% cumulative revision at 14 years across all diagnoses, which is a really good number. However, we do need to be honest about the trade-off. We're accepting a higher risk in the first 3 months, including dislocation and infection, in exchange for removing that late biological cuff failure mode. That's a really good trade, and the average patient who's getting a reverse, who is a 78-year-old patient with low demands. However, it's a harder argument to make in the 55-year-old, which is what we're going to talk about next. So, this slide really helps us to frame our consent conversation because the three implants fail for different reasons. In a reverse, most of the revisions are being done for instability or infection. Both are largely technical and both are to an extent in our hands. We're thinking about soft tissue tension, component version, lateralization, skin preparation, and antibiotic prophylaxis. In the stemmed anatomic, it's the classic cascade of eccentric loading, glenoid loosening, and late cuff or subscapularis failure that results in our revisions. Infection is much lower on the list. These failures are of time and biology rather than specifically how the operation was performed. Stemless sits somewhere in the middle. And note the trend at the bottom. Instability is a rising share of revisions in every class, whilst infection and loosening are beginning to fall as we do these operations better. Instability is now the central technical problem in shoulder arthroplasty. Now, what happens after failure? Basically, every road is leading to reverse, and reverse is the end of the road. Almost every failed anatomic becomes a reverse. That's the salvage pathway. And the modularity means that, more often than not, we're able to keep the original humeral stem, which preserves bone, which is something that is very important, especially if we're doing shoulder replacements in the younger population. When a reverse fails, it nearly always is revised to another reverse. There is no other option. That's something to also keep in mind when it comes to revision rates for reverses, because if we're, as a clinician, at a point where a reverse has failed for any reason, infection, instability, etc., it's a real conversation with the patient about what are our options here. Do we accept this failure mode, and for example, if it's infection, provide the patient with lifelong antibiotics, or if it's instability, do significant activity modification to stop it from dislocating. Those numbers or those discussions with patients resulting in non-operative management means that we may not be capturing all of the reverses that have failed, but we have made a conscious decision to not revise them. The key idea here, again, is that the reverse is the end of the road, and anything at that primary operation that costs glenoid bone or humeral length narrows the options for whoever it comes to revise it later. The other thing we can look at is the size of the operation. Anatomic failure usually means that we need to change both of the components, whereas a reverse revision is often more of a modular exchange and may be less destructive, except of course when it's infected and we need to take everything out. Sex predicts the failure in opposite direction, and this is the finding that can surprise some people. In reverses, men do consistently worse across every major indication, and they are revised predominantly for instability and infection. In anatomics, however, it flips. Women carry a higher hazard ratio, and loosening dominates. One explanation may be that males have higher cutibacterium load and greater torque across a semi-constrained construct, versus in the females having a thinner, narrower, more osteopenic glenoid vault and more degenerative tendon in the postmenopausal women. And these are, again, just plausible mechanisms, not registry findings specifically. The registry only reports association. What this means for the clinician is that we need to have some form of vigilance either way. If you're having a male getting a reverse, we need to be thinking really stringently about infection prophylaxis and the stability within the surgery. And for a female undergoing an anatomic, we need to be having a look at our glenoid bone stock and also the cuff quality before we commit. Now, osteoarthritis under the 60-year-old. What we're really choosing is when it fails. And this is a really hard decision in the young patient. Honestly, there's not something that is significantly better than anything else. All of these 4 different strategies that are shown here land within a couple of percentage points of each other, and none of the comparisons reach any statistical significance. What differs more is the timing, and that's what is useful in the conversation to be had with the patient. Reverses fail in the young, fail early, with high demand patients destabilizing their semi-constrained joint. But then if they survive that first year or 2, then it typically settles. The anatomic options are quite early, have a reduced rate of revision, but then it starts to climb steadily as wear persists and the cuff fails. So with a 55-year-old, we're not necessarily choosing whether they need to have an operation. What we're more so choosing is when and what is our bone stock going to be like. And that reframes the conversation towards bone preservation and the sequence of the operations that the patient may have, rather than specifically the best implant at that time. Finally, we do need to think about the right side of the graph, going out to 10 years with a grain of salt again. There's very few young patients who've had adequate follow-up, and so that graph may end up changing over time. Now, we have 4 choices that the registry says that we can help to change the outcome of a patient. First of all is the polyethylene. So cross-linked clearly outperforms conventional in anatomic replacements, and the same direction holds for reverse humeruses. We've seen this switch already in our hip and knee registry with overwhelmingly positive results. However, our national uptake is still under half of the cases, so this is low-hanging fruit for us to take. Second is stem lengths. So in the stemmed anatomic, shorter stems under 100 mils are slightly worse initially in the first year, but long-term, 49% better beyond 18 months. In reverses done for osteoarthritis, conventional stems have a 2.14-fold hazard ratio beyond 3.5 years. So shorter is better and makes revision easier. On the glenoid side, augmented components perform just like standard ones and have similar revision rates, but fully custom components do not. And the older hybrid metal back designs perform badly. So if you're going to be doing a glenoid, ideally go for a standard or an augment and not a custom. Then we've got the counterintuitive one. Image-derived instrumentation, so PSI guides essentially, are associated with more revision, not less. And that's almost certainly confounding by indication, because we reach for planning in the difficult glenoid. But the useful lesson stands. 3D planning should be used to choose an augment and preserve subchondral bone, not necessarily to justify reaming a retroverted glenoid back to a neutral glenoid. Now, what does this all mean in our next clinic? Really depends on the indication that your patient is presented with. In the elderly patient with osteoarthritis or cuff arthropathy, reverse is a defensible default with really good revision rates out at 10 and even 14 years. In a patient who has a proximal humerus fracture, the conversation is revolving around consent in that first year, specifically because of its early motor failures. And that, again, is to do with our soft tissue tension, our humeral height, and our tuberosities healing. In the patient under 60, we need to change that conversation entirely. We're talking about the sequence of operations across a lifetime and about what bone we're leaving behind, taking into consideration the demands of the patient and the age of the patient with regards to how much working life they have left. Now, if you're going to choose an anatomic replacement, they still have a place, but we need to be able to justify based off the cuff integrity, the bone quality, and the implants that we are choosing, ideally going for one of the implants that the registry shows has the lowest rates of revision. And whatever we implant, we need to remember that the two most common reasons that shoulders are coming back for revisions are the things that are largely under our control. So our soft tissue tension and also rates of infection. 5 things to remember from this talk. First of all, reverse is the workhorse, and it's earned that position by removing the failure mode that we can't really control, which is cuff failure. Stemmed anatomics are meaningfully worse in the long run and largely have left Australian practice, but if you see it used, understand why it suits that particular patient. Stemless matches reverse out to about a decade and preserves bone, but the long-term data doesn't exist just yet, but it's a space to watch and maybe a good option for our younger patients. The failure modes are generally predictable and differ by the implant, and sex can flip the risks depending which one you choose. So we need to tailor our vigilance towards the patient rather than having a one protocol fits all. And finally, the levers that we actually control are unglamorous, but very useful. The bearing surface, the stem length, the glenoid strategy, the stability, and infection prevention. All of these things will help the patient to have longevity with the implant that we choose. Thanks for listening.